Welcome everyone to Health for the World International Grand Rounds. We are honored to have our Grand Round speaker today, Dr. Jeff Dieden. Dr. Dieden is a renowned interventional radiology with extensive experience. Dr. Dieden did his medical school at Hahnemann University School of Medicine, his radiology residency at University of California, San Francisco, and fellowship in IR from University of California, Irvine. Dr. Dieden worked at Kaiser Permanente in Oakland and led the radiology department as chair of radiology there. We are really honored to have Dr. Dieden here to share his expertise with us on patient safety and interventional radiology today. Thank you, Jeff, for doing this for us, and you can start whenever you're ready.
Good day, everyone. I'd say good morning, but it's only morning here and probably not where you are, at least for some of you. It's an honor for me to be able to address you today. I'm going to talk about some things that aren't procedure related, but ways that we can make sure things are safer both for our patients and for our staff and ourselves. And that would be a quality assurance program in the field of interventional radiology. A lot of these principles apply to radiology as well, but since interventional radiology involves more fluoroscopy, it's even more relevant because we are exposed literally to more radiation than the rest of our colleagues. So this is our room. And I'm going to talk specifically about my hospital. This is one of our rooms, I should say. And I just yelled at them through the microphone and they turned around. That's why they have this startled look on them on their face. But this includes one of my physician partners and the other staff, 2 nurses and the technologist that work. So you can see there's a lot of stuff in a United States IR suite. So why QA and why patient safety? Well, at least in our country, it's the number 3 cause of death, at least by some counting of in the country. And that is medical errors. And these have all sorts of ways they present themselves. And the data aren't totally accurate or sure, but the estimate is that over 250,000 Americans die each year as a result of medical errors of a variety of sorts. And it is thought that 3/4 of these are preventable. Obviously, some things, quote, just happen, but most of these things, if we slow down and pay attention, can be prevented. And even more than that, non-fatal things, things that don't kill people, excuse me, cause a number of other morbidities. So let's talk specifics. So the causes are usually system errors and communication, and those are related. More so than a physician not knowing what he or she is doing with a procedure or what medication to prescribe. This is what I'm talking about right now is generic to the whole medical industry, not radiology or IR. So these errors occur not because somebody is stupid or uneducated, it's because the system doesn't support them. And this poor communication includes writing that can't be read, spelling errors, and not writing things down, etc. Medication errors are a big source of morbidity in this country. Not knowing everything about the patient, not reviewing the medical record, allergies and things like that. Falls are another source, especially in the hospital. And then from physician and staff not paying attention to their own wellness, not getting enough sleep, fatigue, burnout, you make mistakes. Other causes are not having enough staff, and there are many others. So we talk about when we do our what we call timeouts, side site, and patient identification, well, what if you bring in the wrong patient and you think you're doing a laparoscopic cholecystectomy and instead, you're supposed to be doing a thyroidectomy? That happens, believe it or not. In our case, if we bring in the patient and we think we're doing an IVC filter, but that's not why the patient got there. What side are we doing? Now, this is more applicable to general surgery, but what if somebody gets their wrong leg cut off? In our case, if we put the chest port try to put it in the side where we already knew that there's a subclavian vein thrombosis, that's going to cause some problems. What if you don't know the patient's allergic to drugs that you haven't reviewed the medical record, or the creatinine is elevated and you give contrast material and put them into further renal failure? What if a patient ate and you sedate them and they regurgitate into their lungs and aspirate? What if you're poking arteries and veins and doing things, doing a TIPS procedure, and the patient's INR is elevated? These are all things we need to know about before we start a procedure. So the point really is, the next slide will really be what your takeaway is, but we can do better. Because all of you practice in different environments and different locations and operate under different regulations and rules and procedures. I can't tell you exactly what to do, but you need to develop a plan for QA. And this is going to result in your patients doing better, and it'll result in your own safety. And especially when I get to the part of radiation safety, your staff will be exposed to less radiation. And once you've developed that plan, it's not a static thing. You should try to change every year. It's like you develop a wellness plan and you learn how to, let's say you jog so many miles a day. Well, maybe you can incorporate a little bit of core into your exercise program, or weightlifting. That's a bad analogy, but you need to improve every year. So you should be proud of your system once you set it up, your plan, your quality assurance program, but it's not a static thing, and you should try to achieve a new target each year, or several new ones. So I'm going to talk about what we did and we do for QA in where I practice, and this will be different everywhere, but it's fairly common in the area where we practice. So these are some of the things we have as part of our QA program. When we get a request or a consultation, we don't consider it an order, because unlike the old days when a surgeon or somebody said, hey, do this procedure, we consider that not a good practice. We consult and give our opinion about whether that procedure is appropriate. So for each one of those orders, or consultations, we have an assigned physician, an IR doctor, who reviews those requests and looks at them and reviews the patient's record and sees if that request is appropriate, and then does a number of other things. If it is appropriate, that physician will make a report form, and this is still done mostly on paper, because we can then hand it off and it can go to the next level, the next staff, the nursing and technical staff, to do their parts of this. But that form, which I'll show you in a minute, includes things: what is the requested procedure? What are the patient's allergies? What are the patient's laboratory values? What medications is he or she on? What is the code status, etc. And then that form gets dropped off in our recovery room, which is the same as our preparation room, where the patients enter before going into the procedure suite, and then they come back to recover afterwards. So that's where the rest of the staff are, and they look at that form, and then they review it all, and then they do their part of the whole setup and the next chain, the next part of the procedure chain. Then there is a specific room set up based on what the procedure is. We have what we call recipe cards and it describes what position the patient's in, what equipment is needed, what medication should be pulled, etc. So the nursing staff and the technologist staff know what they need to do to get ready. This is all before the patient arrives. Once the patient does arrive, we have a safety checklist we go through. We go through a briefing. We go through a timeout. Then when we're done with the procedure, we do a debriefing. Some other things that are part of our QA program, and I'll go through all these things, are audits. People review what we do to make sure we are doing what we say we do. And we have protocols for a variety of things, such as when patients are on metformin. Um, we work in conjunction with our anticoagulation clinic in terms of patients that are on anticoagulation, how we can take them off longer term oral medications and convert them to injectable that are shorter acting that we can discontinue just prior to the procedure to make it less risky in terms of bleeding risk. We also have an extensive physician peer review program that I'll go over. And then the last thing I'll review today with respect to quality is radiation safety. So the first part that I mentioned is that review of the case by the IR physician, who's the consultation doc for the day. So once that request arrives, that's electronic through our medical record system, but the same thing can happen on paper. As I said, that physician reviews it and then looks in the chart, and if it is appropriate, based on what other cases are going on that day and how urgent this case is, says, well, we need to do this in the next hour. We need to do it later today, or we need to do it some other day if it's less urgent and we have other things that are more emergent. So here's that form. Hopefully you can see this, but it includes the patient's medical record number, name, what room if the patient's an inpatient, who started this form, and what the procedure is, diagnosis, history, and then all the important stuff. Can we obtain consent from this patient? If not, then we have to figure out who will provide consent. Has a patient eaten? When was the last time food or drink was consumed? Is the patient on blood thinners? When was the last dose? And then laboratory values, allergies, whether the patient should be monitored on the way down from the hospital. In other words, is this somebody that's in critical care? Is a patient on a PCA medication pump for pain? Oxygen needed? Is it isolation? What primary language? We have a hospital with many languages, and we have translation services for, I think, on the phone for hundreds of languages. But we have in-house translators for about 5 or 6 languages, and we try to make sure that we speak in the patient's primary language when we're obtaining consent, especially. What kind of IVs the patient might be on, whether we're going to be obtaining a pathologic sample, and then we have to pull those forms, for example, for doing a biopsy, and whether or not the patient has had antibiotics that are going to be needed in the case of a dirty procedure. Then below that line, we monitor when the patient arrives in the room, what time. This is for our own internal purposes of how well we do with our efficiency. When the doctor is called, what time we do our timeout, when we start the procedure, when we finish the procedure, when the patient leaves the procedure room. And then there's some other details there. And then the bottom is what the nurse charts for the medications that are given. And this is what I just said. So let's say we're going in the procedure room. Recall that I said we have recipe cards. So if that form says we're going to do a dialysis fistulogram, that has a specific, like several dozen of our procedures, not everyone, but most of the common procedures have a recipe card. So then before the doctor comes in, the technologist will set up this table with all the routine stuff we need, fluids, whatever guide wires, whatever needles, syringes, and other equipment gets set up in a sterile fashion. So we do it electronically, but in addition to that paper form that I showed you, we put a note in the medical record electronically. So the staff then will refer to that, make sure that it actually includes additional information, and we'll then send for the patient when it's time. And then I said we had those recipe cards that include all this stuff. So this is a dialysis fistula declot or a thrombectomy. So there's a brief description of the procedure for the staff. And then this is the position the patient's to be placed on the table, supine with the affected extremity out to the side. And then we mark the site. We have what we call side site marking, and we'll put a yes on the arm that we're going to actually intervene on. Because some patients, some dialysis patients, for example, have a fistula or a graft in both arms, and maybe even some other place. And maybe one's failed and it's been clotted for years, and we may try to accidentally access that one. So we site mark, not with an X, because that could be perceived as no or yes. We write yes. And then some other details about what to do with the drape. Do we need specimens? Well, not for this procedure, so no. What's on the table set up? So this is all the stuff to open, the angiopack, etc. Then which devices to put on the table. And then lastly, these are things to have available, but we may or may not use them, and we don't want to waste them by opening them because they're expensive, but to have them handy, because you don't want to be in the middle of a procedure and realize you don't have everything you need to finish the procedure and to help the patient. This is just that same table from a different view at a different stage of preparation. So again, this is the job of the technologist. And then this is a view, there's that same table off to the right of the room from the head of the table where the primary sedation nurse would be working. And you can see the monitoring equipment there because we monitor patients. We sedate for most procedures. I know that's not applicable everywhere, and we didn't always do that, but primarily for the sake of anxiety, more so than pain, we provide some level of conscious sedation for most things, and occasionally actually general anesthesia, in which case we consult an anesthesiologist who comes in, and we have a whole separate set of protocols for that. So as I said, the nurse, well, usually there are two, the primary nurse that does the sedation stands or sits at the head end of the table and then watches us work, us being the doctor and the technologist, from this angle. Part of the setup includes obtaining the appropriate, so the technologist does the table and the nurse does the medications. So our nurses function as nurse anesthetists, essentially, not under the direction of an anesthesiologist, but under the direction of us. So we order the medications and they're administered as we order them by the procedure nurse. So we have this electronic gizmo called a Pyxis, which houses all our medications in a locked system with drawers. So the medication requested gets entered on this screen, and then the appropriate drawer opens and the medications are in that drawer. The nurse withdraws whatever number of vials as needed and then closes the drawer. And then those medications get registered to that patient, and that's important for follow-up. And then we have back here, just as an aside, a blanket warmer, which is kind of handy new thing in this room. Then we go through a laborious process, which when it was brought in, we did not like. I'll just be frank with you, because it slows us down. But we draw from an analogy from the airline industry. Now we go through this extensive safety checklist to make sure all those things I've been talking about are appropriate before we start the procedure. And so just like the pilots do in a cockpit before they fly, they run through all these things to make sure everything's ready to go. Hey, do we have gas? And do all these electronics work that we can fly the airplane? We do the same thing, and it's broken down by time and by personnel. And so we have a briefing that we do in this yellow section. So there's this big board on the wall that reminds us of these things. And we conveniently have a timer here so that the nurse can record when all these things occur on that form I showed you earlier. And then we do after we run through all the stuff we think we have, and we'll make sure we're ready to go, we do our timeout, which I'll tell you about. Then this happens during the procedure. And then at the end, we do a debriefing, and I'll talk about those things. So I mentioned this, we have a safety checklist. It involves all of us. So at least three. So the nurse, the technologist, and the doctor. Everything stops if the nurse is getting drugs and the technologist is working on the table, then we're not ready. But once the table is set and everybody's got what they need and the physician's in the room, all conversation stops. Everybody gives their attention to the timeout process. And in our case, at least, and then this isn't universally true, the physician runs the timeout. So let's go through some of these things. So again, this is just a slight close-up of what we do. So I'll go through this on this slide, but there's a physician part, the technologist part, the nurse part, and then do we all agree? So what are those things? The physician identifies the patient. So the patient has an ID band, and then we, on his or her wrist, then we ask the patient his name and birth date. Then we verify that the patient is here for the same procedure we think that he or she is for. We verify the side and the site, and we mark it. We verify our position and the ASA score. Then it converts, the attention goes to the scrub tech. So there's a whiteboard that is filled out with all this kind of information. We make sure all the medications and solutions are labeled, that a belt has been applied, the safety stuff so patients don't fall off the table, a wrist strap. When we're using a laser, we make sure that that laser protocol has been set up. We make sure all our equipment is available. We don't want to be doing an angioplasty procedure, a potential one, and realize that, you know, the 8mm stent or 6mm stent or whatever isn't in the room, so that we can't do the whole procedure. And then we make sure the technologist makes sure that the information about that patient has been transferred into the digital imaging system, so that when we record images, they're assigned to that patient's medical record number. Then it moves to the nurse, and he or she will verify that the history and physical has been completed, the consent has been obtained and is correct, that it's been signed and witnessed. We verify the code status, because we don't want to resuscitate someone that is a no code. Check allergies, both for medications, for latex, and for contrast material. We see if the patient's on any isolation precautions. Make sure that the medications are present, and when the antibiotics were given. Check labs, height and weight, which is most important with children, obviously. And then we move on to the anesthesia. If there is going to be some general anesthesia, then the anesthesiologist does that plan. Then at the end of that, in our system, the physician says, do we all agree? And everyone says yes. And if not, then we stop. But if they all say yes, then we start with sedation. And then the physician will say, well, give 100 micrograms of fentanyl and 1 milligram of Versed intravenously ×1 now, for example. And then the nurse reads that back to make sure that he or she heard it correctly, and then we'll administer that medication. So all those things are here, as I just went through, um, before we do the procedure. And that's what we call our briefing. When we're done, we do a debriefing before the patient leaves the room. And this is to help us with our quality assurance after the fact. So this is initiated by the nurse in our system anyway, in our hospital, and he or she will say, is this a good time? The physician then will convert his role. He'll say, this was the procedure we did. We did a thrombectomy of a left upper arm dialysis graft and give the appropriate 5-digit numerical code for the technologist to enter in the book and for many charging purposes. We'll then talk about the sedation and doses of contrast doses, and those get recorded in the chart. We confirm how much fluoroscopy time there was. Then we talk about what the recovery and management is, and we'll say, well, go to the recovery room for X number of hours and get whatever medications, etc. Then, and those will end up as orders written later. Then what do we do with specimens if there are any? And there's a form to fill out for biopsies, for example, or fluids to send to the lab for microbiology. And then anything that happened that caused concern to any of the staff during the procedure. Were there any errors? Because these result in further follow-up. Were there any delays? And that's usually just our own internal efficiency analysis. And is there a need for what we call a post-procedure huddle, where we all collect, possibly bring in a manager and say, and discuss whatever it is that was the concern. And then lastly, as in the operating room, when they do their specimen counts to make sure they get all their sponges back, to make sure there are no retained foreign objects, we obtain an image to verify that. And that's only applicable in IR in our situation for chest ports, because we use sutures to put them in place, and we don't, and we want to make sure there are no retained needles. So this is that right side of the board that discusses those things I just mentioned. So we do have a sedation protocol. So as I mentioned before, the physician orders the drugs, and both the name of them and the dose, as well as the route and timing. They are administered by the nurse after a readback. And then, like I said, sometimes we have an anesthesiologist or a CRNA performing general anesthesia for us for a particularly painful or unusual procedure. And then after the briefing, I went over all this already. And then we record the medications at the end. We do a number of audits. The universal protocol audit is something where, on an occasional basis and usually unannounced, a manager or some administrator will mosey into the control room and watch us to make sure we do all the things I just talked about, and to make sure we run through our checklists and do our timeout the way we're supposed to, for example. And then they fill out the forms and go back. And then they report to their senior leadership on a regular basis. And then if we're not doing things properly, then stuff happens later and we get advised, chastised, whatever. We also have a pathology specimen audit tool because one big quality assurance problem that happens commonly in a lot of hospitals is specimens are lost. You would think that wouldn't happen, but you'd be surprised. Even in a modern hospital, you obtain a biopsy or some fluid and it doesn't make its way to the lab, or even if it does, what happens to it there? So we have a protocol to make sure that that specimen arrives, because the last thing you want to have to do is stick a needle in an organ that's very vascular and put the patient through a second risk procedure at risk for bleeding because you lost the biopsy specimen. And then because we operate in the surgical suite, we're behind what we call the red line. We're in the operating room, which is not common, but increasingly happening for a variety of reasons. IR is within the operating suite, so we have to work under those rules, and that includes how we wash our hands. So that gets monitored as well. So here's the form that is used for the universal protocol audit. This is the specimen audit. And then this is one place where we wash. And so they will sit there and say, was hand hygiene performed correctly using the World Health Organization method, etc. So that's the end of that section. I'm going to move on to physician peer review. This is a big thing, and it's a source of anxiety among physicians, not a constant one, but we know that we're always being watched. And that's a good thing up to a point. And so let's run through that. So when a peer review referral comes, that's basically a question, not quite an accusation, but did everything go properly? Did this procedure, did the performance of the physician, was it done properly up to the standard of care? And so those and it's good to review these, and we do them on a regular basis, and we meet monthly. So the referral can come from yourself. If you're doing a procedure and the physician doing the procedure is the one most likely to recognize an error. And so many of our referrals, possibly the most, come from ourselves. Something goes wrong and you realize, oh, maybe I should have used this wire instead of that wire, or this catheter, or maybe 7 millimeters was too big, too large for that artery, and I should have used a 6 millimeter stent. So we will self-refer and start a case. Equally commonly probably comes from another one of our colleagues who say, I operated on someone 3 weeks ago and the patient comes back for another procedure, and my colleague reviews the case and realizes, whoa, that doesn't seem quite right. I'm going to look into that. So it doesn't have to come with a lot of research. It just has to go to the referral for the QA coordinator to be reviewed later. A referral can come from another department, and that's common. It can come from our quality department. If they review charts, which they do, and they find something that seems amiss, they can start an audit. It can come from our risk department, which reviews general practices in the hospital for purposes of trying to reduce risk to patients and themselves, and also from our legal department, especially if somebody files a medical malpractice suit, then it comes from them. So then what happens when we get a referral? We go through a formal review of the case. So we meet monthly, and it's a committee of the IR physicians. Probably ought to actually involve other people, but as of the time I retired, that was the way we did it. And so we anonymously discuss the case and assign scores to it. And there are two sets of scores. One is called the P score, referring to the procedure, and the other is an S score, referring to systems. And they go in P012 and S012. And the 0 means in the case of P0 means the procedure was done appropriately into the standard of care. And an S0 means there were no system issues and the system supported the procedure and everything was appropriate. P2 is the other end of the spectrum, means that the procedure was done outside the standard of care and was inappropriate. And an S2 means there was a serious systemic failure that led to a bad outcome. In between those, as you can imagine, are intermediate scores that we call room for improvement. And sometimes that's a little bit vague, but It's where something meets, in the case of a P, the standard of care, but is still technically and legally, but still isn't optimal and should be reviewed. So then what happens? Those reports are written up by the QA coordinator, and they get sent to the quality department, and they get stored there. And depending on how many of those reports for one physician occur in a certain amount of time, it will serve primarily as a self-learning. But if there are too many of them, then there are disciplinary ramifications. And those physician discipline can include, at the most basic level, retraining. Say 3 times a physician gets a P1 in a particular procedure, that rings a bell that maybe that doc needs a little refresher on how to do that procedure. So it'll involve retraining, usually from a colleague. It may involve ongoing monitoring to see how that physician works for a subsequent number of months. And in the most severe cases where things are egregious or multiple, we can lose our privileges. So changing gears again, this is actually an extensive field, and I have more information in these slides that I care to go through in detail, but I will introduce the concept. Are we doing on time? Because this is something that affects not just patients, but us, meaning the operators and our staff. And it affects us more because we are exposed to radiation on a daily basis. Our patients, hopefully, only come down once or occasionally, and their dose is much less. On the other hand, they're the primary recipient of the direct beam of the radiation, so we need to care about that as well. So why do we care about radiation? This has been going on since we discovered it over 100 years ago. And especially some of the testing from the nuclear bombs or some of the early data where we learned about some of the radiation effects. But we know that it causes cancer and other things, including cataracts. We know that there is no known safe dose, although depending on the physics and the theory you subscribe to, at the lowest doses, there is some level of safety, we think, at intermittent low doses. But depending on the lines, we want to minimize the dose as much as possible. So we look at risk benefit. So as I mentioned, interventional radiologists and staff, we get years and years and years of radiation. So our cumulative dose is high. So we need to be more careful with ourselves than we are with our patients. And we don't know the extent to which our repair enzymes work to fix our DNA mistakes and other things the radiation does to our cells. And the long-term cumulative low dose exposure, it poses risk, but how much? And so some of these things are approximations. So leukemia is a common associated malignancy with radiation exposure. And this is known from the nuclear blasts in Japan and in the islands in the South Pacific. Thyroid cancer is a well-recognized consequence of radiation, and cataracts are. I can tell you in 2015 and 2013, I had my eyes fixed because I developed cataracts in each of my eyes and had to have them fixed in my 50s. So let's just talk about the most basic things. We only want to do ionizing radiation related procedures when we need to. So that's why we review the case to see if it's appropriate, not just for other reasons of safety, but we don't want to be radiating people and ourselves unless the procedure should be done. So just not willy-nilly. This is only applicable in certain procedures, but if it can be done under ultrasound guidance, use that. There's no ionizing radiation. But when the majority of time, we're going to be using fluoroscopy. And so we need to do the other things to minimize dose. And that is use less fluoro time, acquire fewer images when we're obtaining actual images, and do other physical things to reduce dose. And shielding is obviously the most important. And then also focusing on the exact ways that we can reduce scatter based on the physics of radiation. We'll talk a little bit about that. There's a concept called image wisely, and it's a set of basic principles that I went over, and you want to reduce your fluoro time and basically what that last slide included. So before the procedure, you want to know where you're irradiating the patient, what part of the body, and you want to know, is there some part of the body that's already been irradiated or has had recent surgery or infection. If we're going to use a lot of radiation, some people advocate getting informed consent. This would, for example, be a TIPS procedure that might be complicated and use a lot of dose. And I already mentioned ultrasound. And we obviously need to wear radiation protection. And there are some specific guidelines for what that means. But obviously, an equivalent of a 0.5 millimeter of lead on our apron, but also a thyroid shield, lead glasses, or something equivalent to that. And sometimes other things. Some people wear gloves that shield radiation. We always monitor our dose. So that's a basic principle by wearing a badge that gets reported every month. And when our numbers are too high, we get advised to maybe do a little SIR the next several months. Shielding is critical. There's a lot of details to this. But in addition to what I said, what we wear, it's what we put around us. And we like to use a skirt under the procedure, unless it's a really awkward position the patient's in where we can't put a skirt on the table that shields our lower body from scatter emanating from the patient's body. We have rolling shields that can be moved when the skirt isn't appropriate. And we actually, you saw one in that picture when the nurse at the head of the table, she stands behind a rolling shield. Then there's some other things about pregnancy. Again, this is very detailed and I don't want to go into all the stuff. The physics are really important. Collimation is really important and really easy to do. It takes a few extra seconds to collimate to the field of view, and it really protects the patient and you. We have advanced equipment, so we have these things called last image hold. So if you're on fluoro, instead of acquiring an image or a series of images, when you take off your foot, the picture is preserved and you just push a button and it goes to the digital archive instead of using extra radiation to acquire a different image. And then the physics get in. You want to put the table as high as possible and have the patient as close to the image intensifier, et cetera. Angulation, it results in extra dose, et cetera. So here are some things you don't want to do. This is trying to get a needle under fluoroscopy into a dialysis fistula. I took this while I was consulting in another country. And this is just the difference between collimation. You don't want to be taking pictures of air. What does that serve? It's just irradiating things. And it also results in lousier images. So, like I said, the image intensifier is close to the patient. And these are all things you can look up about the physics. And you want to communicate among the staff about what you're doing, et cetera, et cetera. We have where I practice is the state of California, we have a number of requirements and standards that get monitored, but this applies to us and not the patient. So because again, we're receiving the dose over a cumulative period, we want to make sure we're protected there aren't a lot of protocols or regulations that apply to patient safety. We do record them in a number of systems, but not a lot is done with that data yet. CT doses, for example, all get recorded in the medical record. And then lastly, I'll just, there's another acronym that goes around ALARA, as low as reasonably achievable. And that's something to keep in the back of your head as a general rule of thumb. This is a very manual fluoro book that we put in the patient's medical record number. And on the right, you can see what their fluoro time and what their MA and KVP were. And that comes straight off the machine. Okay, that's the end of radiation safety. We have a whole set of protocols, and I won't bore you with that. But what to do with our waste, and that includes chemotherapy, blood products, and other waste that comes off the table or the patient. We actually have an interventional MR suite. So that has some very unique challenges dealing with metal in that environment. And there's a whole set of safety requirements that we have there. So you can see this is the door, and I actually have never been in that room. So concluding, before we offer the opportunity for you to ask questions, just be aware of the issue that medical errors kill people and they injure people. So that's the back of your mind. And commit to safety. Just say, yes, I'm identifying this as an issue that's important to my practice. Start with a basic plan and work from there to improve. And the key is communicating, both during a procedure, but before and after. And don't forget radiation safety. And that is the conclusion of my talk.
Thank you so much for the excellent lecture, Dr. Dieden. And our audience seems to have a couple of questions for you. Hakim Al-Hashimi says, very impressive setup. I'm interested in knowing how you deal with interruptions from other non-IR staff, in example, other doctors, etc.
Talking about during a procedure, I presume.
Yeah.
Well, they don't come in the room. They aren't allowed. So that's usually true. Rarely something will happen, but again, we're behind the red line. We're in the operating room, so it's unique, and that's not the way it was before we moved to our new hospital. So that protects us there. But in the more usual environment where IR is part of radiology, then yeah, sometimes they used to come into our suite, sit in the control room, wave at us, hey, I have a consult. I think you just have to be, since you're in charge, you're the captain of that pilot, you're the pilot of that airplane, you got to decide whether, are you at a point in this procedure where you can be interrupted, and how urgent, and that kind of thing. So it's just I would say common sense. And if you're not, and you feel comfortable that person's not going to have you fired somehow for not consulting with him or her right away, then you just have to say, what I'm doing with this patient now takes precedence. But you know, obviously there are some settings where you can step off for a few seconds and do that. So it really depends on local politics. I don't know the dynamic behind that question. So, but in our setting, we consider ourselves the boss of everything. And so I'm saying that slightly tongue in cheek, but really we're responsible for our patients, and that's first.
Okay. Now, Scott Du asks, I'm interested in what you do if the reference KERMA exceeds 5,000 mgy for the procedure.
The short answer is I don't know, because I'm not a radiation physicist, and I don't know specifically what those numbers mean. But if they exceed any of our thresholds, they get reported, and then we have a conversation. They say, why, you know, it initiates one of those audits. Why did you continue with this procedure with so much dose? And we have to justify. And if we say, I was doing this complicated tips and I was really close to the end, and this patient's been bleeding to death from esophageal varices, I had to do this. I assessed the risk of radiation skin damage to be less than the risk of immediate death, then, but you would be called up to justify why you did that.
Okay. Dr. Nasrina says, very informative talk. Was concerned if there is any medical legal concern in exceeding the radiation dose, especially in pediatric patients.
I'm sure if egregious there is, but I've never heard of that. People are aware of the risk. We're really, really, really aware of it with respect to kids. I really don't like doing long procedures of any type with kids. We all know we're especially cautious, not just with kids, but teenage, especially with girls. It's easier to shield, testicles than it is ovaries. So we're very conscious of all that. I don't know of anybody ever being sued for irradiating a child excessively, but I suppose that's possible. Why did that come up?
I think that those are the only questions. I just want to thank you again, Dr. Dieden, for doing this. I know that this is your second time with us, and we hope to see you again with us in the future. And thank you so much.
My pleasure, and happy holidays, and please stay safe, everyone.
Thank you. And I'm just going to take a few seconds to share our fundraiser event real quick.
Certainly.
Yeah, we have a fundraiser event to help countries that have been hard hit due to COVID and provide them some personal protective equipment. And you can access the platform to donate in our website here. And you can donate whatever you can, whatever you want. Every help is more than welcomed. Thank you so much.
All right.
Have a good day and happy holidays, everyone.